Imagine you're sitting in a hospital room in 1948. You suffer from severe anxiety, or maybe severe depression or schizophrenia. The doctor walks in. He isn't carrying a scalpel, a drill, or a surgical plan. He's carrying a gold-plated ice pick he pulled from his kitchen drawer and a pair of electroshock leads. 10 minutes later, without a single sterile drape, without a breath of general anesthesia, and without an operating room, your brain's prefrontal cortex has been permanently severed. And the man who did it gets back into his camper van, a vehicle he unironically calls the Lobotomobile, and drives to the next town to do it 10 more times before dinner. This isn't a creepypasta, it isn't a horror movie plot. This was cutting-edge American medicine in the mid-20th century. Today we are looking at the terrifying history of the lobotomy, specifically through the lens of modern neuroanesthesia and neuroscience. How did a procedure that looks like an active assault win a Nobel Prize? How did an ambitious neurologist turn a bloody surgical procedure into an assembly line roadside show? And what actually happened to the human mind when that ice pick hit its mark? Let's step into the dark room of psychiatric history. To understand why the lobotomy took off, you first have to understand the nightmare of 1930s psychiatry. Before modern psychotropic drugs, before Thorazine, Prozac, or lithium, asylums were less like hospitals and more like human warehouses. Hundreds of thousands of patients were trapped in states of profound psychosis, mania, or catatonia. Staff were overwhelmed, treatments were crude, ranging from freezing insulin baths to malaria infection, and families were desperate. Enter Dr. António Egas Moniz, a Portuguese neurologist. Moniz was inspired by an experiment on two chimpanzees named Becky and Lucy. Scientists had removed the primates' frontal lobes and noticed the chimps became remarkably calm. Moniz asked a radical question: if severing the frontal lobes stops a chimp's emotional outbursts, can it cure human madness? Moniz created a procedure called a prefrontal leucotomy. He drilled holes directly into the top or sides of a patient's skull and inserted a tool called a leucotom, a needle with a retractable wire loop. Once inside, he'd deploy the loop, rotate it, and core out small plugs of white brain matter, cutting the connection between the emotional centers of the brain, the limbic system, and the decision-making brain, the frontal lobe. Moniz claimed staggering success. He reported that his patients became calmer and easier to manage. In 1949, Egas Moniz was awarded the Nobel Prize in Physiology or Medicine. Think about that. The highest honor in science was given for cutting holes in human brains to calm them down. Now let's pause here and talk about this from a modern medical perspective. When a modern neuroanesthesiologist prepares a patient for a craniotomy, a procedure where we open the skull, the preparation is immaculate. We monitor intracranial pressure, cerebral blood flow, oxygenation, and EEG waves to protect every single millimeter of functional brain tissue. Brain tissue does not regenerate. Every track cut by a blade is gone forever. Moniz was blind cutting through complex vascular and neural architecture, but as crude as Moniz's procedure was, an American doctor was watching, and he thought, "This takes too long. I can make it faster." His name was Dr. Walter Freeman. He wasn't a surgeon, he was a neurologist, and he had a flair for showmanship that would make a circus ringmaster jealous. Freeman took Moniz's leucotomy and rebranded it for America as the lobotomy. But Freeman had a massive bottleneck. Drilling through the skull required a surgeon, an operating room, sterile conditions, and time. Freeman wanted to bring the lobotomy to the masses. He wanted an assembly line, so he looked for a shortcut into the human brain, and he found one, right through the eye socket. The bone separating the back of your eye socket from your frontal lobe, the orbital roof, is paper thin. Freeman realized he didn't need a drill or a scalpel. He just needed a thin, sharp spike. In 1946, Freeman performed his first transorbital lobotomy. Where did he get his first tool? Literally from his kitchen drawer. It was an ordinary ice pick. Here's how the procedure worked, and brace yourself, because from a modern clinical perspective, every single step of this is a nightmare. First, anesthesia, or rather the complete lack of real anesthesia. Freeman didn't use an anesthesiologist. Anesthesiologists asked too many questions, required patient monitoring, and slowed things down. Instead, Freeman used an electroconvulsive therapy, ECT machine. He would administer 3 consecutive electrical shocks to the patient's temples, intentionally inducing a grand mal seizure. As the patient lay unconscious in the post-ictal phase, the state of coma-like confusion following a seizure, Freeman had a window of about 2 to 3 minutes. Freeman would lift the patient's eyelid. He placed the point of the ice pick directly under the eyelid, resting against the thin bone at the top of the eye socket. He took a surgical mallet, or in some cases a literal hammer, and tapped the end of the ice pick, punching through the bone directly into the frontal lobe. He plunged the pick roughly 2 to 3 inches deep into the brain tissue. Then, he swept the pick side to side, severing the neural pathways. He pulled the pick out, repeated the exact same steps on the other eye socket, and was finished. Total time elapsed? Under 10 minutes. No sterile field, no gloves in many cases, no blood pressure monitoring, no airway control. Just a man, an ice pick, a hammer, and a helpless patient recovering from an induced seizure. Let's step back and analyze this from a modern neuroanesthesia standpoint, because the sheer lack of medical safeguards here is staggering. In modern surgery, general anesthesia does 3 things. Unconsciousness, you aren't aware. Analgesia, you don't feel pain. And akinetics, muscle relaxation, you don't move. Using electroshock seizure as a substitute for anesthesia fails every single one of these standards. When a patient undergoes a grand mal seizure, their heart rate spikes, their blood pressure skyrockets, and their brain demands massive amounts of oxygen. The brain is literally exhausted and hypercongested with blood. Plunging a sharp metal instrument into a hypercongested brain with soaring blood pressure is an absolute recipe for a catastrophic intracerebral hemorrhage, a stroke or bleed in the brain. If a patient shifted, twitched, or came out of the post-ictal state early while an ice pick was shoved 3 inches inside their skull, the pick could lacerate the anterior cerebral artery. The patient would bleed out inside their own brain in minutes, and Freeman knew this happened. Patients died on his table from massive brain hemorrhages. Others suffered severe paralysis, permanent blindness, or uncontrollable seizures. So why did society let him keep doing it? Because of the miracle cure bias. Before lobotomies, violent or severely psychotic patients screamed, tore at their clothes, or required constant physical restraint. After an ice pick lobotomy, those same patients sat quietly in a chair. They stopped screaming, they ate their food, they obeyed commands. To a desperate medical system and overwhelmed families, this looked like a miracle. What they were actually seeing wasn't a cure. It was the catastrophic destruction of the human ego. The frontal lobe is the seat of your personality, your planning, your empathy, your foresight, and your inner voice. By sweeping an ice pick through that tissue, Freeman wasn't curing the illness. He was destroying the part of the brain capable of expressing it. As one critic famously put it, they made a wilderness and called it peace. By the late 1940s and early 1950s, Walter Freeman was no longer just a doctor. He was an evangelist on a mission. He bought a camper van, which the press and medical community dubbed the Lobotomobile, and set off on road trips across North America. He drove from state hospital to state hospital, performing demonstration lobotomies for crowds of eager, wide-eyed doctors, media reporters, and hospital administrators. The theatricality was sickening. Freeman loved to show off. He would perform two-handed lobotomies, inserting ice picks into both of a patient's eye sockets simultaneously to impress the audience. He timed himself trying to beat his personal speed records, sometimes finishing a dual lobotomy in under 3 minutes. On one occasion, while posing for a photograph during a procedure, his hand slipped. The ice pick penetrated too deep into the patient's midbrain. The patient died instantly on stage. Freeman didn't stop. He wiped the pick off and moved to the next patient. He lobotomized adults, the elderly, soldiers returning from World War II, suffering from shell shock, PTSD, and even children. His youngest patient was a 12-year-old boy named Howard Dully, whose stepmother brought him to Freeman because the boy was defiant, moody, and daydreamed. Dully spent decades wondering why he felt broken, only learning as an adult that his brain had been sliced up in minutes when he was a child. And then there was Rosemary Kennedy. Rosemary was the sister of future President John F. Kennedy. She experienced mild developmental delays and mood swings as a young woman. Fearing her behavior would damage the family's political aspirations, her father brought her to Walter Freeman in 1941. Freeman performed a lobotomy on the 23-year-old Rosemary. During the procedure, Freeman had her talk to him and sing songs while he cut away brain tissue, stopping only when her speech became completely unintelligible. The result? Rosemary lost her ability to walk, speak fluently, or care for herself. She was institutionalized for the rest of her life, hidden away from the public eye for decades. Over his career, Walter Freeman personally performed over 3,500 lobotomies. Nationwide, an estimated 40,000 to 50,000 Americans underwent the procedure. How did this nightmare finally end? It wasn't a sudden moral awakening. It was chemistry. In 1954, a drug called chlorpromazine, marketed in the US as Thorazine, was approved. It was the first effective antipsychotic medication. For the first time in human history, medical science could calm a manic or psychotic brain without driving a piece of steel into it. Thorazine was hailed as the chemical lobotomy. But unlike Freeman's ice pick, its effects were reversible, controllable, and non-destructive to the physical brain architecture. Almost overnight, the lobotomy craze collapsed. Freeman was increasingly marginalized by the medical community. In 1967, after a patient died of a brain hemorrhage during her third lobotomy by his hands, Freeman was finally banned from practicing surgery. He spent the rest of his life driving his camper van across the country, visiting former patients, desperately trying to write papers proving his life's work hadn't been a catastrophic mistake. He died in 1972, unrepentant. Looking back from a modern medical perspective, the story of the lobotomy isn't just a story about a rogue doctor with an ice pick. It's a cautionary tale about the entire medical establishment. It shows what happens when desperation meets hubris, when a society is so overwhelmed by a health crisis that it accepts a violent shortcut without demanding rigorous scientific proof, long-term outcome tracking, or basic patient safety protocols. Today, neurosurgery and neuroanesthesia operate under strict evidence-based guidelines. Advanced procedures like deep brain stimulation, DBS, allow us to treat severe neurological and psychiatric conditions with microscopic precision without destroying brain tissue. We look back at the Lobotomobile with horror, but we must also look back at it with humility. It reminds us that the line between a groundbreaking medical miracle and barbaric cruelty often comes down to one thing: asking the hard questions even when we want a simple answer. What do you think about Walter Freeman and the era of psychiatric surgery? Let me know in the comments below. If you found this deep dive valuable, hit that like button, subscribe, and click the notification bell to join us for our next journey into medical history. Until next time, stay curious and stay safe.